right. Thank you, thank you. All right, let's get started. We have a short time to talk about a lot of things. And I haven't been coming to this as long as some people here, but I've been coming a long enough time that even now as people are filtering in, there are way more people than I remember from doing this several years ago. So we're going to talk about this study, longitudinal associations of corticosteroid dose with corticosteroid toxicity in patients with myasthenia in the US. Financial disclosures, and should note that this is a study sponsored by Alexion. So all of us know that corticosteroids are common, the linchpin treatment for myasthenia today and ongoing. But we also know that they have acute and long-term adverse effects, side effects, and we all try to taper these. And it's been pretty well established that the complement inhibitors and ravulizumab shown here have a pretty significant steroid-sparing effect. You can see on the left-hand side there from the Champion open label that at the beginning a fair amount of people on a decent dose of steroids, and then by month 24 the vast majority of patients under 10 milligrams. And then from claims databases, people starting a complement inhibitor, starting ravulizumab, starting out at less than 5 milligrams, only 30%, and then 50% at the end of the 12, 18-month follow-up. And you can also see from the MG Spotlight registry and ravulizumab, and then people switching from eculizumab to ravulizumab, a significant decrease in the dosage of steroids. So in our study, we aimed to quantify, using a retrospective cohort, the dose and steroid-related toxicity in a large real-world population. And we did this by the typical methodology here. Adults with multiple myasthenia gravis, ICD-10 code claims separated by at least 30 days, excluded people receiving corticosteroids 6 months prior to their index MG claim. And this is electronic health and claims data from Kronos and Forian. And we used an outcome measure that I think some of us are well aware. This is the glucocorticoid toxicity index metabolic domain. So this is a subset of this index called the GTI, which was developed to assess the toxicity and the change in toxicity in patients receiving corticosteroids in treatment trials for rheumatologic, pulmonary, and other disease, and has been incorporated increasingly in lots of different trials. And there are two key components to understand about this. There's a cumulative worsening score, a CWS, which is a snapshot before and after the growing toxicity. And then there's an aggregate improvement score, which still, if the score is higher, is more toxic, even though it says improvement, because you can get points subtracted if your BMI drops, your lipids drop, et cetera. And the metabolic domains is composed of just BMI, A1C, blood pressure, and LDL cholesterol, so easy data to collect. So here is our overall sample, and you can see whittling down to a full analysis, a set with 24 months follow-up in pharmacy claims, 20,634 patients. But then when you get to the analysis where you can actually calculate the GTI-MD and changes in it, that number shrinks dramatically. Largely this is because of poor relationship with the EMR and claims databases, and lots of patients not having data for LDL and A1C. So you can also see that in that subset, the majority of patients now have diabetes. So I think that this is, to point out retrospectively, there can be some issues for why we find that, but I think in clinical practice, as I'm going to show you, I think this is a useful metric. I think if we're not checking them or people don't have PCPs checking them, these are things that we should be checking for our patients on steroids. And then we looked at cumulative corticosteroid dose in that population, and this is just sort of charted out what the baseline daily dose is, what that would be over 24, 18, 12 months. And in this analysis population, 45% of our patients were less than 1,000 milligrams, 4% greater than 20,000 milligrams over this 24-month period, and everybody else in this range in between. And what I really want to get to is this slide. So this is using this GTI-MD steroid toxicity by cumulative dose. And on the left, you see the cumulative worsening score, the CWS. And on the right, you see the aggregate improvement score. Now, this is a retrospective study looking at people into the future. So on the aggregate improvement score, we're not going to calculate improvement. We're not going to be able to see people dropping off as they're starting a new therapy, which is what that metric is designed for. But you can see that anybody with a cumulative corticosteroid dose greater than 1,000 milligrams has a significantly increased risk for having a higher cumulative worsening score and aggregate improvement score. And again, the aggregate improvement score being higher is worse. That's more toxicity. And then you can go back out to the full analysis subset, away from just the small GTIMD population. And here you see in our 20,643 patient, where we couldn't calculate the GTIMD in everybody, you still get this same effect where at each subsequent dose of corticosteroids, an increasing prevalence of hypertension, diabetes, obesity, sleep disorders, fractures, the things we all know we're trying to avoid when we have patients on steroids. So conclusions here, we're able to demonstrate that cumulative corticosteroid doses of greater than 1,000 milligrams over a 2-year period associated with higher steroid toxicity as measured by the prevalence of steroid-related adverse events, as well as significant differences in the clinical worsening score, the cumulative worsening score, and the aggregate improvement score in the GTIMD. And you can see that that's true in both of these different subsets. So I think the GTIMD here offers a very quick, easy snapshot, able to quantify the burden of steroid use and the adverse events. And when you look at the limitations, why our subset was so small, I think that one criticism or one thing to think about is that if we're not routinely measuring these things, that this is a very well validated scale, perhaps we're missing some of the overall burden and impact of steroids in our patients in regular clinical populations. And using this in a prospective manner, including this in upcoming clinical trials, I think would be a useful thing to help us assess the burden here. And with that, I will finish up with 4 seconds to spare. So, thank you very much. And I will have Dr. Pascuzzi come on up, and I'll get you going.
Thank you. Bob Pascuzzi, Zionsville, Indiana. I'm going to spend a couple of minutes talking about one of my favorite topics, steroids and myasthenia. If you've been in these meetings for 40 years, it's a very historical topic. So I'm going to talk about a post hoc look at corticosteroid dose tapering in the rozanolixizumab study for patients with myasthenia. Let's see. Disclosures, introduction. I don't have to tell anybody about steroid benefits. I think they're great, but the downside is huge, and that's why this is an important topic. And I don't think I have to explain much about rozanolixizumab, this FC receptor blocker that's currently approved for generalized seropositive myasthenia. The objective of this study is to look and see what happened to corticosteroid dosing during the course of this clinical trial. It is important in the initial Mycarin study of rozanolixizumab, in the initial treatment phase, 6 sub-Q infusions, and then monitoring, the patients had to come in stable on corticosteroids if they were taking steroids for 4 weeks before baseline. And then during that initial phase of testing, one could not change their corticosteroid dose. But when they went into the extended portion of the study with repeated cycles of the drug administered based on patient symptoms and at the discretion of the investigator, the investigators could change corticosteroid doses any way they wanted. So the corticosteroid dose was not a primary outcome measure, so this is truly a post hoc analysis where there was no guidance to the investigators what to do. All right, this has been shown previously just to kind of illustrate the duration of this study, the improvement in MG-ADL, and give you a sense as to the context for this. Okay, so let's talk about the corticosteroid situation. Not every patient in this study started on corticosteroids, about half of them. If you look at the patients who were on corticosteroids at baseline, a third of them over the course of the study could reduce or discontinue their corticosteroids altogether. There are some that actually had to start on steroids and increase. I'll show that. The median dose was 15 milligram. This is of prednisolone equivalents per day, and it dropped to about 4 prednisolone equivalent milligram per day. And there was about an even split between those that dropped their steroid dose and those who stopped altogether. The question is, well, how long do you have to wait in a study in the setting of getting this medicine before steroid doses were reduced? About half the patients had their reduction initiated within the first 24 weeks, which would be about 2 or 3 cycles of the drug therapy. If you look at all patients, including those that were never on corticosteroids, 2/3 of them had no change whatsoever. And this helps illustrate also the patients who actually started or increased corticosteroids. So the bottom gray part is the 40% of patients. They were never on steroids throughout the whole study, and so there was no change. There's a 27% of patients, 33 out of the 121 patients altogether, who didn't change their corticosteroid dose. Their mean dose, which may be important, was 7.49 milligram per day. There is a concept that there's a Cushing threshold above which a daily dose is more likely to cause more severe, serious, long-term adverse side effects, and below which there's a relatively better safety profile. This is all relative, and that's 7.5 milligrams a day. And so that was the basis for looking at some of these doses. Are they above 7.5, low 7.5 milligram per day? And at least those that didn't change their dose were on this relatively lower dose, on average, the mean 7.49. And then 7 out of the 121 started on corticosteroids during the course of the study, and another 7.5% increased their corticosteroid dose. Actually, of interest, the increase in steroid dose went from 6.3 median milligram per day to 23. But looking at data is kind of interesting, because the last recorded daily dose was a patient that got IV methylprednisolone, a massive dose, which kind of changes the statistical environment. So if you look at patients that were on corticosteroids to begin with, who were taking more than 7.5 milligram per day, this Cushing effect dose, there were 53 of those patients, and 41% of them reduced or stopped their drug during the course of the study. This cartoon illustrates what happened to all 53 of these patients. The top line is the 10 out of 53 that stopped altogether. The next line is those who got below this magical 7.5 milligram dose per day. The next set, those who reduced but not below 7.5. The big group that really had no change, remember their mean dose was also in the 7.5 range. And then the 8 out of 53 that had to increase their dose of corticosteroids. So this gives you sort of the full spectrum of what happened. As has been previously published and demonstrated, the drug was generally well tolerated, and I think that's well known, but want to be complete in showing that. So what would one conclude from this interesting kind of post hoc analysis for somebody who's obsessed with steroids and myasthenia? I'd say, number one, the rozanolixizumab showed sustained long-term efficacy over repeated treatment cycles, and during the course of this study, a third of the patients who are receiving corticosteroids at baseline were able to reduce or discontinue their dose, about an even split between the two, and the numbers are helpful. And then on the patients who were on the higher corticosteroid dose, more than this Cushing threshold, 7.5 milligram, a little over 40% were able to reduce or stop their corticosteroids while on cyclical treatment. And so I think these post hoc findings support the observation of reduction of corticosteroid use in patients treated with an agent such as this. And I think that is my 5 minutes and 48 seconds, and no time for a joke. Thank you very much. please. I don't want to screw this up and mess up your presentation. You don't have to.
All right, staying on theme. All right. Right, I'd like to start by thanking the MGFA for allowing us to present our work on reduction in oral glucocorticoid use at 18 months following efgartigimod initiation based on a United States claims database. Here are our financial disclosures. This research was funded by argenx. As you all know, glucocorticoids or GCs are mainstay therapy in GMG and are associated with many short and long-term side effects, especially when used in higher doses and for longer periods. Evidence of GC reduction is critical to support treatment decision-making with targeted therapies. Efgartigimod was approved in the US in 2021 for the treatment of anti-AChR antibody-positive GMG based on the safety and efficacy demonstrated in the ADAPT trial. There are several case studies globally that have demonstrated substantial GC reduction with efgartigimod use. We recently published that GC dosing significantly decreased after 12 months of continuous efgartigimod therapy based on 266 patients from US claims. So the objective of this study is to evaluate longitudinal changes in GC use among patients with GMG using chronic GCs who initiated and continued efgartigimod for 18 months. So our study is a retrospective cohort study using an insurance opens claims-based data set from April 2016 to January 2025. We also had MG-ADL scores from the MyVivgard Path Patient Support Program dataset. Regarding our exclusion and inclusion criteria, patients had to have at least 18 months of ongoing efgartigimod usage based on claims captured. The first efgartigimod claim had to be between January 1st and June 30th of 2023. There had to be presence of GC claims during the 1 year prior to efgartigimod initiation. Patients had to have continuous quarterly claims activity to minimize missing data, and they were excluded if there was evidence of concomitant use of C5, rituximab, or non-efgartigimod FcRn inhibitors along with efgartigimod. Regarding outcomes, we looked at the change in average daily dose, or ADD, of GC at 3 months, which was defined as 60 to 90 days, 6 months, which was defined as 150 to 180 days, and so on at 3-month intervals until up to 18 months. We also looked at patients that had an average daily dose decline of at least 1 milligram per day. And in that group, we looked to see how many had a 25%, 50%, or 75% decline in that ADD compared to baseline. For a subset of patients, we also had the change in MG-ADL from baseline over this time period. So here is a pictorial view of our study design and inclusion and exclusion criteria. Baseline was the first treatment with efgartigimod, but we looked at the 1 year prior for oral steroids claims, and then the patients were observed for 18 months. So there were about 2,200 patients with first efgartigimod claims between January 1st and June 30th, 2023. Of those, 1,748 had continuous quarterly activity. Of those, 1,387 had no concomitant therapy. Within that group, 518 had evidence of chronic GC use prior to efgartigimod initiation, and of those, which was our final cohort, were 167 who remained on efgartigimod for 18 months. So here are our patient characteristics. The gender and insurance type were well balanced. The characteristics were similar to what was seen in our 12-month cohort. There was a high proportion of comorbidities, including hypertension, and greater than 75% use NSAIDs and or other advanced GMG therapies with GC prior to efgartigimod initiation. So here are our results. Oops. Let me try over here. Okay, sorry, I'm trying to get the pointer. All right, never mind. All right, I'll bring your attention to the table on the bottom. So our first outcome was to look at the average daily dose of oral steroids. So you can see on the bottom left that at baseline, the ADD of steroids was 16.6, which went down to 12.8 at 6 months and further down to 7.5 at 18 months. And you can see the p-values below. These changes were statistically significant. And now I'll bring your attention to the bar graph, which has the color coding of the different ADD dosing groups. So you can see that at baseline, about 13% were in the light green, which was 0 to 5 milligrams of prednisone, all the way up to the purple, which was 13%, and those were patients that were on 30 milligrams or higher of prednisone. And as we proceed along the x-axis, you can see the shift of patients to the lower dose groups. And so by 18 months, about 30% of patients are in that dark green, which means that they're off of steroids, and only 3% are on greater than 30 milligrams daily. At the 18-month mark, 55% of patients are on GC ADD of 5 milligrams or lower. And so here's our second outcome. So here we looked at the subpopulation of patients who had at least a GC-AD decline of 1 milligram a day. And in that group, we looked to see how many had a 25%, 50%, or 75% decline from baseline. So you can see that at the 3-month mark, about 90 patients, or 54%, had at least a 1 milligram AD decline of GC. And in that group, 86% had dropped by 25%, and 59% by half, and 41% by 75% of their baseline ADD dose. And by 18 months, 72% had at least a 1 milligram ADD decline of GC, and of those, 93% dropped by at least 25%, 79% declined by half, and 61% by at least 75%. In about 88 patients, we were able to match the patients from the IQVIA database to MyVYVGART path and get MG-ADL data. As you can see in the 18 months of continuous efgartigimod treatment, the average mean MG-ADL in this population dropped rapidly after initiation by about 4 points and further dropped to almost 5 points by quarter 6. So in conclusion, in this real-world cohort of chronic GC users, 18 months of continuous efgartigimod therapy led to a significant and progressive reduction in GC use while retaining improved MG-ADL scores. At 18 months, the mean GC dose was reduced by over 50% from baseline, going from 16.6 to 7.5. The majority of patients, 55%, achieved GC ADD of 5 mg or less, and 30% had no GC usage. Among the subset of patients with MG-ADL data captured, there was a significant and sustained improvement in MG-ADL score to about 5 points. Regarding strengths, the study enabled inclusion of a large sample size with longitudinal follow-up, with results supporting reduction of GC use with the use of efgartigimod observed in previously published case series. Regarding limitations, claims-based data analysis are subject to several inherent limitations, including assumptions, potential coding errors, and risk of missing data. Also, insights into how prescribers are approaching GC tapering on efgartigimod were not assessed and require alternative data sets to explore. Thank you. I had a question for Dr. Ragole. So I noted that in your patients that had no steroid exposure, they still had elevated GTI-MD scores. Any thoughts on that?
Yeah, so the GTI-MD is not a 0 if you are not on steroids. If you are an American and you have a rate of obesity or metabolic syndrome or elevated cholesterol, you're going to have an elevated score. And it's pretty well known that people with any autoimmune disease that have higher risk of being obese, of having hypertension, et cetera, even without being on steroids. So I think that that's probably what we're seeing.
I have a question for both of you. Is this working? It's not working.
It's working.
Yeah, okay, sorry. For Dr. Goyal, I'm wondering in your cohort, because you're following people for 18 months, and most of us would taper steroids in patients being followed for 18 months. I wonder if you were able to account for the other non-steroid medicines that they were on, and did you look at the population that wasn't getting efgart, and what happened to their steroid dose?
So we didn't have a comparator cohort that was not on efgartigimod, so that's harder to say. And I believe for the NSISTs, those were also reduced, but the numbers were smaller.
And then maybe for both of you. So it's interesting, we're talking about measuring the burden of steroids, but as a community, we're moving away from using steroids, I think, in many of our patients. And I'm wondering how these units are going to be able to measure the side effect burden of FcRn inhibitors, complement inhibitors, non-steroidal oral medicines, et cetera.
I think that's a good question. And the development of the whole GTI was this big consortium of rheumatologists, pulmonologists, neurologists, lots of folks. And it was specifically looking at the things that we know that steroids do to people. But I think that as we look at, other therapeutics, the complement inhibitors, FcRns, the B-cell depleting drugs that are coming, we could, as a community, create a consensus-based, validated measure to look at toxicities or issues with that. And I think that is, definitely worth considering and, and putting that into some of our upcoming trials.
So I think that's a great question, Mike. So we have completed a study looking at about 50 patients in MG using the GTI to look at steroid toxicity. And although it's a great measure, I think there's still a lot of limitations in that it's proprietary and it is quite costly to use it. The unit that you and your colleagues have created, the AEU, I think is excellent in that it really does allow us to not be as focused on steroids, but really to think about the burden of toxicity for all of our agents. So I think the GTI is great in that we're moving towards being very scientific and really quantifying it, but I think there's room for improvement.
All right, so I have time for one more question, please.
Sure, I'll give it a go. Thank you.
Dr. Goyal, this is a question for you. So based on the data that you shared, it looks like there was chronic GC usage before the Vyvgart initiation in about, say, 500 patients, and the data was presented for about 160 patients, so a third of that. So curious what happened to the remaining patients. Were they not on therapy for 18 months, or did they wean off of the therapy for whatever reason?
Yeah, that's a great question. So yeah, based on the inclusion-exclusion criteria, we only looked at that subpopulation. We didn't look at the population that didn't have efgartigimod used for 18 months. So we don't have that information.
Got it. So just to clarify, 518, that the larger number that existed was 18 months or less. Is that fair?
Exactly.
Thank you very much. I appreciate it.
Our next session is meningococcal infection and immunization. So if I could have Dr. Lokesh Jha join me.
So thank you, first of all, the MGFA Scientific Session organizers, steering committee members for allowing us to present our analysis at this esteemed forum. And I think this is important piece of information that we wanted to share with the providers. I also want to thank the first author, who is Ukunakpoji, who is my colleague and my team member who could not be here to present this because he's on a parental leave. So I would do my best to make sure that the message and the data that we have analyzed gets across to you. Okay, sorry, somehow I think clicker is not working. So these are our financial disclosure. It's purely Alexion employees that have worked on this with people from safety team and biostatistics team, and we are all employees of Alexion AstraZeneca. Introduction, we all know that the C5 inhibitor therapies, such as eculizumab and ravulizumab, are indicated for 4 major indications, which is PNH, AHUS, GMG, and NMOSD. We also know, it's a very well-known fact, that C5 inhibitor therapies carry the risk of Neisseria meningitidis infection, and antibiotic prophylaxis is advised in patients not up to date with vaccination. But the most important part, which I want to harp on, and the reason why we did this analysis, is the third one, which is limited data exists regarding the optimal antibiotic drug selection and treatment duration for patients who receive antibiotic prophylaxis. And the reason is that if you look at any label, the class label of C5 inhibitors, the treatment regimen and the duration of antibiotic is not mentioned, and it is up to a physician to select an antibiotic and the duration they want to give that prophylaxis. Even in our trials, if the patient did not start within the 14 days of the first dose of vaccine, physicians could decide on themselves whether they want to use antibiotic or not and for how long. And this is the reason why we did this analysis. So the objective of this post-hoc analysis was to examine the antibiotic classes used and the duration of prophylactic antibiotic used in phase 3 clinical trials in adult patients who received at least 1 dose of eculizumab or ravulizumab for any of the 4 approved indications. The study that we have taken is all the adult studies, adult patient studies, because in PNH, AHUS, especially AHUS, we have pediatric studies as well. This is the study design and analysis. So this is a descriptive post-hoc analysis, wherein we just looked at all the patients who took antibiotic prophylaxis, who were adult patients and who participated in our clinical trials. On the right-hand side, if you look at the waterfall chart, there were 944 patients that we analyzed from our phase 3 trials. 582 patients did not take antibiotic prophylaxis, or they did not have antibiotic exposure, while 362 patients did have. Remember that even if anyone took even 1 day of antibiotic prophylaxis, they will be in the 362. But the biggest information that came up when we analyzed this data is in the lowermost side. So we actually did the regional variance of antibiotic usage, and you see that there was an overwhelming usage of antibiotic prophylaxis in ex-US patients versus US patients. So only 8.8% patients in US used antibiotic prophylaxis versus ex-US, which is 91.2%. And if you further break down the indications in which they were used, it was, again, majorly leaning towards the PNH and AHUS, and very less for GMG and NMOSD. So one of the analysis that you will see going forward is that we try to look at the antibiotic-related adverse events in the patients, because we have patients who have used antibiotic prophylaxis for a variety of duration, and we wanted to see that what was the percentage of patients who actually encountered antibiotic-associated adverse events. Now, moving forward, I would be calling it as AESI, or adverse event of specific interest. So these are the baseline demographics and disease characteristics. So it's a well-balanced. There's less patients on antibiotic prophylaxis side versus those patients who only took C5-IT. The patient in terms of race are pretty balanced. There are more patients from Asian descent who took only C5-IT. But one thing that I want to draw the attention is that in the regional variance, you see that patients from Europe, there is 64.9% patients coming from Europe who took antibiotic prophylaxis among all the groups. The C5 inhibitor exposure in terms of years of exposure is pretty balanced, around 2.9 years. And the total C5 inhibitor exposure in trials in terms of patient years of exposure, you can see it's close to 1,000 patient years in this group versus 1,609 patient years of exposure only in the C5-IT group. And we think that this is a good control group where they are not taking prophylaxis versus this group who were taking prophylaxis. This is another very interesting information that we saw. And here you see what you call a dichotomy. And although US patients are very less, as I said, 8.8%, they were all coming into the shorter duration of antibiotic prophylaxis timing. So you see here 31.3% for US took only for 14 days or till 14 days, while another 34.4% took for a month maybe. So, but then there was nothing in between. You see how less percentage of patients who took for between 31 to 90 or 91 to 180. But then there is a huge leaning from the ex-US side where it was used for more than 1 year. And this is very important, in my opinion, because we can get the information from these patients as how the AESIs have evolved in these patients over the period of time. And you will see that how we have dichotomized those epochs of time to see that how those AESIs related to antibiotics have evolved. This is the slide where there was no discordance in the US or ex-US. This is where there is a lot of agreement and consensus in terms of which antibiotic to use. So whether you are a US patient or ex-US patients, penicillins were the class of antibiotic that was used the mostly. And then other beta-lactams were also used. After that, it's a fluoroquinolone. Remember, this is a combination of GMG and all other indication. So we have to keep that in mind. These were the AESIs, and I want to draw some attention as how we chose these AESIs related to antibiotics. We looked at two very major publications from Mosin and Tama that was published in 2017 and 2020 respectively, and they looked at these AESIs of antibiotics in a community practice as well as in hospital patients. And when you combine that, and they also looked at all the FDA labels of antibiotics to see that what were the most common adverse events associated with antibiotics. And they were basically classified into these 4 or 5 categories, starting from gastrointestinal disorders, well-known AEs, and then skin or subcutaneous tissue disorder that includes allergy, or if there was an allergic reaction, then the infection and infestations, immune system disorders, and musculoskeletal. If you look at this, which is also very interesting, that if I go by the major classification here, 88.5% patients had gastrointestinal disorders who took antibiotics, but also the same or similar AESIs happened in those patients who did not take antibiotic prophylaxis. So this was very interesting for us to see that how balanced this was. This is something which I thought that we must share with the providers, what we observed. Then we also looked at the grades of those AESIs and looked at that how balanced or unbalanced, if they are, across these two groups. And this is also very interesting that most of the AESIs, whether you look at the prophylaxis group or non-prophylaxis group, most of them were grade 1 or grade 2, which is mild or moderate, as we know through the CTC-AE criteria. And if you go to grade 3, grade 4, or grade 5, you have hardly any of those AEs occurring. But the best part is the balance between the two sides. Now, this is another important thing. So I just want to take a moment here to say that why we use these epochs of duration to see the AESIs. And we wanted to line it up with the vaccination practice, or we say the vaccination practice as recommended, right? So we looked at the epoch to see that how many patients or percentage of patients got any AEs within 2 months, and then between 2 to 6 months, and then between 6 to 12 months, and more than 12 months, right? So you see here, one of the interesting observations is that whether you are taking prophylaxis or not taking prophylaxis, the numbers are stable. I'm not surprised with these red bars numerically a little higher, because you would expect some antibiotic-related adverse events in those groups who are taking antibiotics. But these numbers were stable despite the duration you are taking. And remember, these are separate epochs. So if a patient was there on a therapy for 12 months, the events that happened within 2 months are only in this category. If they had any event between 2 to 6, they are in this category. So they are separate epochs that we looked at. But suddenly at the 12 months, or more than 12 months, you see 31.1% patients who took antibiotic. This is another important information. We wanted to see that any of these AESIs really led to discontinuation of C5IT or the therapy they were on. But it was very reassuring for us that for the AESIs that we observed, most of the patients resolved, which is 90.8%, and they continued C5 inhibitors. So there was hardly any discontinuation. So overall conclusion, I think antibiotic prophylaxis duration varied upon initiation of C5 inhibitor therapy, with most US patients receiving only between 1 to 30 days of treatment and ex-US patients receiving more than 1 year. Penicillin was the most frequently used antibiotics, which is actually consistent with the recommendation of European guidance if you see in the patients with complement deficiency. The most common AESIs were gastrointestinal, mild to moderate, all resolved. In the first 12 months, proportion of patients reporting AESIs were similar in both groups, which was very interesting, and which kind of tells us that it is optimized prophylaxis duration may limit long-term antibiotic-related AESIs. And there was a strong tolerability profile. Most of the AESIs were resolved, and less than 1% patients discontinued C5IT because of those AESIs. So thank you so much for the opportunity. Again, I thought this data would be important for people to see. Thank you again.
Thank you. Dr. Pandya?
All right. Well, thank you so much for everyone, for MGFA, for the opportunity to present today on this very important topic. And I think I had a great introduction from Lokesh, to this important topic around meningococcal infections with the terminal complement inhibitors, eculizumab and ravulizumab. So good afternoon. My name is Shirali Pandya. I'm a medical director at Alexion. I'm really pleased to be sharing the meningococcal infection data today in patients with generalized, with generalized myasthenia gravis and neuromyelitis optica spectrum disorder. And this is a US-specific analysis. Having trouble with this. Oh, there we go. All right, so these are disclosures. We are all employees of Alexion. So many of you know, of course, eculizumab and ravulizumab are terminal complement inhibitors. Both drugs are currently approved for anti-acetylcholine receptor antibody-positive GMG and anti-aquaporin for antibody-positive NMOSD, as well as other non-neurological indications. Targeted inhibition of the terminal complement pathway increases patient susceptibility to infection with certain encapsulated bacteria, including Neisseria meningitidis, while preserving other arms of the immune system. Due to this increased infection risk, patients on complement inhibitors should be vaccinated against Neisseria, and vaccinating early could also be an option to preserve treatment optionality for patients and allow for timely initiation of C5 inhibitor therapy. Other comprehensive risk mitigation measures include the drug safety programs like the REMS program, and patients should of course be properly counseled and educated on the risks associated with complement inhibitor therapy. So the objective of this analysis is to report on the Neisseria meningitidis infection rates in the US post-marketing setting that we've seen at Alexion for eculizumab or ravulizumab treated patients across approved indications in the US, with a specific focus on GMG and NMOSD treated patients. And this is, of course, we understand from all of you in the community who tell us that the risk, they would like to understand the risk in their specific patient populations that they see in the US in myasthenia and NMO patients. So in this US-based analysis, eligible patients who initiated C5 inhibitor therapy may have either been vaccinated against Neisseria meningitidis at least 2 weeks prior to initiating a C5 inhibitor therapy, or in the event that urgent therapy was indicated, antibiotic prophylaxis could have been provided. And finally, meningococcal vaccines could have been administered as soon as possible. And finally, a provider could have vaccinated in advance of prescribing a C5 inhibitor. For those patients, they considered potential future candidates for therapy. So here are the methods used in this analysis. Data from the Alexion pharmacovigilance database were analyzed for eculizumab and ravulizumab across all approved indications. And all Neisseria meningitidis infections were included, including cases that were from the first US approvals for these drugs. So the data you'll see today include a total of 17 years of data since eculizumab's first approval and 7 years of data since ravulizumab's first approval in the US. Cumulative reporting rates were calculated per 100 patient years, which is often used to communicate levels of risk to regulatory agencies. And this concept is used to account for the fact that patients are exposed to drug for varying lengths of time. I'll try to make this concept a little bit more tangible in the interpretation of the data for the GMG patients. All right, so now looking at the data itself, I'd like to show you the cumulative Neisseria meningitidis infection and associated mortality rates for eculizumab in the US. As a reminder, these are post-marketing data for US patients exposed to eculizumab for all 4 indications for which it is currently approved. So what you're looking at right now is actually the exposure data, and the blue curve represents the cumulative exposure to eculizumab over time since its first approval. As of October 2024, there were over 36,000 patient years of cumulative exposure to eculizumab in the US across all 4 indications. This fuchsia line represents the cumulative Neisseria meningitidis infection rates, showing a cumulative meningococcal infection rate of 0.13 per 100 patient years. And this mustard line represents the cumulative Neisseria meningitidis mortality rates in the US over time, which is stabilized at approximately 0.01 per 100 patient years. So over time, increasing exposure data has provided greater confidence in the cumulative infection rates. Now looking at the corresponding cumulative meningococcal infection and mortality rates for ravulizumab in the US, we can look at the cumulative exposure to ravulizumab. By the end of 2024, we had over 15,000 patient years of cumulative exposure to ravulizumab in the US, again, across all 4 indications for which it is currently approved. The cumulative meningococcal infection rates shown here, where at the end of 2024 were 0.06 per 100 patient years. And then again, looking in yellow at the mortality rates, that was stabilized at 0.01 per 100 patient years. So finally, I'd like to show you the infection rates as promised among patients with GMG or NMOSD treated with either drug in the US post-marketing setting. So as you can see, there have been 4 infections amongst GMG patients treated with eculizumab in the post-marketing setting in the US with over 10,000 patient years of exposure. And this has resulted in a meningococcal infection rate of 0.04 per 100 patient years. What this means is, like the way I like to explain it, is that there's a probability of observing one meningococcal infection case if one GMG patient is exposed to eculizumab for 2,500 years, which of course doesn't seem very reasonable, but another way of saying it is if one, or equivalently, one meningococcal infection if 2,500 GMG patients were exposed to eculizumab for 1 year each. There have been 2 infections amongst NMOSD patients treated with eculizumab in the post-marketing setting with over 2,000 patient years of exposure, resulting in a meningococcal infection rate of 0.08 per 100 patient years. And finally, there have not been any infections amongst GMG or NMOSD patients in the US treated with the ravulizumab in the post-marketing setting to date, as of data cutoff, with over 4,300 and 200 patient years of exposure in each indication, respectively. There have also been no reported Neisseria meningitis-associated fatalities in the US post-marketing setting for the neurological indications. So in conclusion, the meningococcal infection rates in the US have demonstrated consistency with previous analyses from post-marketing reports, and the rates have remained relatively stable over time. As of data cutoff, there have been no reported meningococcal infections on ravulizumab-treated GMG patients in the US, as I mentioned, and there have been no reported meningococcal fatalities in the GMG or NMOSD-treated patients in the US on either drug. That suggests to us that vaccination, antibiotic prophylaxis, the REMS program, and other risk mitigation strategies in the US are effective. And finally, risk mitigation strategies such as early vaccination, antibiotic prophylaxis are effective and critical measures that can help prepare patients in case of urgent C5 inhibitor therapy initiation. So with that, I want to thank you all for your attention. There is a code here you can scan for the presentation and the slides. So thank you very much.
So we'll do a brief Q&A. We have about 3 or 4 minutes, and I would invite people to the microphones for their questions. While we get, Dr. Vu's ready at the mic, so I was going to have a question. Dr. Vu, go ahead.
So for the 4 patients on ECU with MG, how soon after treatment did those patients develop the infection?
So for the neurological indications, thank you, Dr. Vu. We've seen a wide variability in terms of the onset of the infections. I believe we've seen for the neurological indications anywhere from the 21 days to 1,200 days in that range. So again, wide variability in terms of the onset of the infection from treatment initiation.
A couple of questions. I truly appreciate Alexa actually being very open. I did request medical information regarding meningococcal infection risk. It seems to me the number a little bit higher than this. Maybe because this is a U.S. population, the outside U.S. there are more infections. Is that right?
Yes. So we did do this analysis looking. There is a global publication that looked at the global rates that was recently published. I'd invite you to look at that publication. This analysis was focused on the U.S. and again, specifically the neurological indications, again, to really understand the risk profile for those specific patients.
Thank you. The other is we physicians, especially neurologists, are asked to prescribe antibiotic prophylaxis. What we generally don't worry about is the side effects, but what we worry about is the drug tolerance, the antibiotic tolerance. That is, if we keep on giving penicillin 5 to a patient, and in the future, when a person develops infection, they may no longer respond to penicillin 5. I don't know if, for the first speaker, that your AESI truly reflect that event.
Yeah, thank you for the question. So definitely not. I think with the tolerance, you meant resistance to the antibiotic or development of resistance to the antibiotic. So we could not do that because for that, we will have to see that anyone who got the infection, were they susceptible to the antibiotics or which antibiotics? So I think that needs a bigger project on a community or a population level to see that how long an antibiotic needs to be used so that someone develops the resistance. But I agree with you, antibiotic resistance is a problem.
So I have a question. This is probably for the both of you, but the cases of meningitis, do you know if those patients were on prophylactic antibiotics at the time?
So we have some information on their vaccination status. I believe that these patients were not reported to be on antibiotic prophylaxis.
And do you know if they had were up to date with their meningococcal boosters and things of that sort?
There is a history. All of them, at least the GMG patients, were vaccinated. But beyond the kind of knowing that they were on at least one dose of vaccines and booster information was not complete.
And Dr. Mupidi?
Quick question for Lokesh. We tried to avoid fluoroquinolones in MG, and I was surprised to see that was the second most common after penicillin.
Yeah, so that's a good question. So I would put a caveat there because it includes all the 4 indications. We did not break it down between the indication. But to your question, I would encourage you to look at the paper that was published by Yubing Lee Group from Cleveland Clinic, where they actually looked at the risk of antibiotic-associated MG exacerbation, and the rates they saw of the exacerbation was actually very low as historically reported or perceptually thought. In fact, they saw that only MG hospitalization and female sex and comorbidity of diabetes was actually correlated with the exacerbation, not which antibiotic you used.
Well, so this is more homework for Dr. Novak. The MGFA website has not changed the fluoroquinolone recommendation. My patients check the website. So.
Excellent. Well, that concludes the vaccination session. We'll move on to the diagnosis, diagnostics, and management considerations.
Thank you. Next up, I'd like to introduce Dr. Juan Camilo Ibarra-Jurado. And as Dr. Nowak mentioned, this will be our last session. Can't believe it went by so fast.
Hi, good afternoon. My name is Juan Camilo Ibarra. I'm from Universidad Nacional de Colombia and present my research impact of botulinum toxin on the electrodiagnosis of myasthenia gravis, a case series. I don't have financial disclosures to report. Ptosis is a frequent reason for refer patients to electrodiagnostic laboratories, often to confirm or exclude neuromuscular junction disorder, such as ocular myasthenia gravis. However, in many cases, referred patients lack compatible clinical features. This results in a low pretest probability and consequently reduces both the performance and the clinical value of electrodiagnostic testing. Ocular myasthenia gravis is an autoimmune disorder caused by antibodies directed against acetylcholine receptors. This disrupts neuromuscular transmissions, reduces induced excitability, and produces muscle weakness. Similarly, botulinum toxin acts at the neuromuscular junction by inhibiting acetylcholine release. Single fiber electromyography is a highly sensitive and specific test for neuromuscular junction and is essential in the diagnostic process of ocular myasthenia gravis. However, prior botulinum toxin exposure may directly interfere with single fiber electromyography results. Evidence on the duration of these effects is limited, especially when assessed in small facial muscles. We perform a retrospective case series, include patients with ptosis, referred to our electrodiagnostic laboratory to single fiber electromyography, who have received previous facial botulinum toxin injection in the previous 12 months. The study period was from Jan 2024 to May 2025. Data were collected from medical records and single fiber electromyography reports. Single fiber electromyography was performed using a Natus Nicolet-Bakis system, following international standard for neuromuscular junction testing. Settings include frequency filter from 2 to 10 kHz, gain of 100 microvolts per division, and sweep speed of 1 millisecond per division. Electrical stimulation was applied using a monopolar needle electrode, and recordings were made with concentric needles. Abnormality was defined as a jitter greater than 21 microseconds in frontalis and 27 microseconds in orbicularis oculi, or the presence for more than 2 abnormal potential or over 10% abnormal potential. Results. We include 6 patients, 5 women and 1 man, aged 24 to 75 years. All patients were referred for single fiber electromyography due to ptosis. Ptosis has been present from 3 to 7 years. None had fluctuating, diplopia, fatigue, diurnal variability, proximal weakness, dysphagia, or other signs suggestive of myasthenia gravis. All patients previously received botulinum toxin for aesthetic purposes. Ptosis was unrelated to the injection. It was neither a complication nor a post-injection symptom. The time from the injection to single fiber electromyography ranged from 3 to 9 months. Details on the specific toxic brand and dosage were not available. 3 patients were tested in the frontalis, 2 in the orbicularis oculi, and 1 in both muscles. Increased mean jitter was found in all patients. The number of the fiber potential analyzed varied from 8 to 24. Some studies were made with lower potentials due to the clear abnormality found. All patients had abnormal single fiber electromyography, which in the context of their clinical presentation were attributed to prior botulinum toxin exposure. This prevents definitive interpretation, led to inconclusive diagnostic errors. Although the toxin effects on the neuromuscular junction is generally reported for 4 months. In our series, we observe a possible residual effects for up to 9 months. The literature does not clearly define the maximum duration of this effect, especially when assessed in small facial muscles, such as orbicularis oculi or frontalis. This importance ask about prior botulinum toxin exposure before single fiber electromyography. The importance of wait period between injection and testing, and it's a point for future research to define the optimal time between injection and testing. Thank you.
Thank you. So we've got 2 more presentations. Dr. Suehiro is up next. Oh, there you are.
Thank you for the opportunity to present in MGFA Scientific Session. The title is Diaphragmatic Compound Muscle Action Potentials Correlate with the Clinical Severity of Myasthenia Gravis. No financial disclosure to report. I'm speaking about the introduction. Patients with Myasthenia Gravis, or MZ, often experience impairment of respiratory function. We focus on diaphragmatic compound muscle action potentials, or DC-MAPs, obtained by using single stimulus phrenic nerve conduction studies. Some reports have explored in patients with generalized myasthenia gravis, or GMZ, had lower DC-MAP amplitudes. Our aim was to investigate whether the DC-MAP amplitude correlates with the clinical severity of MZ and improves with treatment. I'm speaking about methods. We retrospectively evaluated consecutive patients with MZ who underwent right phrenic nerve conduction studies between 2013 and 2023. We evaluated first the differences in DC map amplitudes between patients with ocular MZ or OMZ and ZMZ. Second, the correlation between DC map amplitudes and the clinical severity of MZ. Third, the comparison of DC map amplitudes pre and post treatment in patients with ZMZ. Method of phrenic nerve conduction studies. We placed recording electrode placed 5 cm above the xiphoid process and reference electrode placed over the right anterior costal margin 16 cm from recording electrode. I'll introduce the typical waveform of DC map. There are just 2 examples. The amplitude of the DC map is lower in the ZMZ patients at 150 microvolts compared to 356 microvolts in the normal subjects. Result 1, clinical characteristics. This study group included 76 patients with MZ, 30 patients with ocular MZ, and 46 patients with generalized MZ. Data are presented as medians, interquartile range, percentages, or n values. There were no significant differences in sex, age, weight, presence of thymoma between 2 groups. Patients with OMG had significantly lower anti-acetylcholine receptor antibody titer, MG-ADL scores, and QMG scores than in patients with ZMZ. These results obtained from patients with MZ are considered consistent with those in the Japanese population. Result 2. Comparison of DC map amplitudes between the patients with OMZ and those with ZMZ. DC map amplitude was significantly higher in patients with OMZ than with ZMZ. Median values were 364 microvolts in the patients with OMZ and 212 microvolts with ZMZ. In addition, DC map amplitude was almost equal between patients with OMZ and normal subjects. Result 3. Correlation analysis between the CMAP amplitude and the clinical severity of MZ. We examined correlations with clinical severity scores. The DCMAP amplitude showed moderate negative correlations with both MG-ADL and QMG scores. That means when disease severity increased, the DCMAP amplitude became lower. The correlation coefficients were minus 0.52 and minus 0.60. Result 4. Comparison of DCMAP amplitudes pre and post treatment in ZMZ. In patients with generalized MZ, the DCMAP amplitude increased after treatment. The median value improved from 184 microvolts to 336 microvolts. This slide shows summary of results. First, DCMAP amplitudes correlate with the clinical severity in patients with MZ. Second, the DCMAP amplitude increased after treatment in patients with ZMZ. The slide shows discussion. Severe neuromuscular junction disorder may reduce CMAP amplitude with a single stimulus. The diaphragm is expected to be more susceptible to impairment in patients with MZ, causing reduced DCMAP amplitude. DCMAP amplitudes reflect treatment response in patients with ZMZ. DCMAP may serve as an electrophysiological marker of therapeutic efficacy in patients with MZ. We think that these facts suggest that assessing the respiratory muscles, which are constantly working throughout the day, is highly sensitive to fatigue. In conclusion, DCMAP amplitudes may correlate with the clinical severity of MZ and reflect the treatment response. We propose that DCMAP measurement be included in the evaluation of patients with MZ. Thank you for your attention.
Our thanks again to the organizing committee for allowing us to present this. I'm not going to give you data. I want to give you thoughts and concepts. And to start, I think we often talk the walk, but we don't walk the talk. And shared decision-making is something that we never had in our lexicon 10 years ago. Probably in very few lexicons 5 years ago. And given the plethora of what's coming in the pipeline and what we have now, this is a term that's being used more and more in meetings that I'm involved with. These are our requisite disclosures. So despite the growing number of treatment options that our patients have available to us and what we're going to see in the next 5 to 10 years, I still think we have significant unmet quality of life issues. And part of that is because we don't often try to determine what's the goal of the patient. We have our goals. We want people with no symptoms, minimal to no adverse events, but in some individuals that's probably not appropriate. The 85-year-old guy who sits at home and likes to read a newspaper and doesn't go out, for instance. Does he have to be perfect? And Pushpa would argue that absolutely not. And so shared decision-making is a collaborative process in which individuals and clinicians work together to develop treatment plans. I think we all think of this in the back of our minds, but very often we really don't do it. To consider the benefits, to consider the risk, and then to develop what is the optimal care plan for that given individual. And while shared decision-making has demonstrated positive outcomes in many other chronic conditions, it's really not been explored in the MG world. And so our colleagues developed a comprehensive desktop analysis. Was conducted looking at over 50 sources of information, including peer review articles, practice guidelines, educational resources, conference proceedings, etc., extracting information to assess prevalence, the rates of implementation, and outcomes across a number of therapeutic areas, highlighting patterns, barriers, etc. And then trying to look at this to enable and what was relevant to the care of our myasthenic population. And the findings that came out of it, and I'm not going to give you the actual data, that's in a poster later this week, was that SDM, shared decision-making, allows prompt and more accurate diagnoses, it improves the quality of our decision-making, and enables providers to choose treatment pathways best suited for the particular individual. It enhances engagement and satisfaction with the patient who has MG, therefore improving quality of life, and it addresses psychological and social needs, two areas where I think we fail completely addressing the mental health of our patients with MG. And then it reduces the demand, ultimately, for healthcare resources and sets realistic expectations. This is just one example. It's the Ottawa Personal Decision Guide, where what's the decision you face? What are your reasons for making this decision? When do you need to make this decision? It gives the options, it gives all of the pros, and one ranks the importance of each of those, of each option. It gives you the cons to using that particular therapy, for instance, and then one ranks how you interpret or how you believe or what you feel those cons will impact you. And these can serve as practical resources to help guide the patient through this process. I think the MS folks, they're 10, 15 years ahead of us in dealing with not only therapeutics, but also these sorts of things. And if we take the center column, how do we address disease-modifying agents? Is it immune modulation, reconstitution, blocking, and then separate those into what those compounds' assets are, and then go through this exercise with the patient. Yes, it takes time, but I think there are going to be ways that we can use technology to help facilitate this in the future. And so what are the pros and cons of using a beta-pheron versus cladribine versus naturalizumab, et cetera? And how does it meet the expectations of the individual? In doing that, it then allows both the clinician, healthcare provider, and the patient themselves and their family, for instance, to come to a shared decision as to what we implement is in the best interest of me, the patient. And so it is applicable to MG. And we believe, those of us looking into this, that we can implement things in the future that will help. We'll be able to align on values and preferences. We can discuss the current life circumstances. We can ensure that providers are aware of our comorbidities, what are our short-term goals, what are our long-term goals, et cetera. We can problem solve conflicts that arise because of whatever choice we think we want to make, but no, that's probably not the best, and we can look at treatment pathways down the line. We can look at the treatment options and the aids that align with the values that we want as we try and reach our ultimate goal. And we can help the individual understand why treatment is recommended, what are the best assets, what are the problems that we have with it, and then they can understand the risk-benefit ratios. And then we can discuss the inputs. The patient has ideas. They come to us often with a sheaf of paper saying, I want this. And we can then use this to step through the pros and cons of each of those decisions. So I think in the future, we need to integrate shared decision-making into our clinical management team. It doesn't need to be you, the clinician, though you will play an important role in this, but it can be our nursing staff, our social workers, if we're lucky to have them, our pharmacist who's in the clinic with us as well, if you're lucky to have that, and then enhance the dialogue. It's the dialogue that becomes critical, I think. We can then empower the individual to take an active role in their care, and it allows us to better understand the lived experience. Nancy Law, who many of you may know, and some may not know, was a huge proponent of the lived experience of myasthenia, she herself having it, and directed this organization for a number of years, and is a firm believer in that it's an absolute critical element. And as the treatment landscape changes, and we have this huge growing menu of options, where do we position? What are the pros? What are the cons? Can we use these tools to help guide us in this process? And I believe we can. And perhaps it's a topic for the MGFA roundtable discussions that we have every year, and add it to follow on from the lexicon. So I think embedding these practices in our continued care is going to be the way to go, and I thank you very much.
And that concludes this session. We have plenty of time for questions. Chip, don't be in such a rush to leave. I can take this. I actually do have a question, about the shared decision making. what might the role of multidisciplinary care be in the care of patients with myasthenia?
Oh, I think multidisciplinary care is critical. Very few of us in the U.S. are fortunate to have a MG-specific multidisciplinary care system. We were in Barcelona a week and a half ago at a RDCN meeting, and in Britain, they have specific MG nurses, and all they do is MG, and they're aligned with the physician and help guide the process. We're fortunate to have a pharmacist we have to share with neuroimmunology, but has become quite adept in dealing with our MG population. We don't have a social worker, which I think is critical to any team with a chronic disease like this. We don't have a psychology staff that I think is absolutely critical, because mental health, you saddle somebody with a diagnosis of MG for life. If you had cancer, you go to your first cancer appointment, you're surrounded by a nurse coordinator, you're surrounded by a social worker, and they guide you through all the way to your cure, till you die. And we should be doing that in chronic autoimmune disease. We don't have the resources, and we've got to figure out a way around it. But multidisciplinary teams are absolutely important.
I'm going to leave the mic with Chip, because I'm anticipating questions.
Yes, I have a question for Chip. Thank you for starting this conversation up again. And just briefly, I have a lot of thoughts about this, but what are your thoughts about AI as part of the way to facilitate shared decision making?
Yeah, I think AI is potentially a way we can go once we have the language so that we're not going down the wrong path. I think AI is still in its infancy for this kind of a topic, screening compounds for potential pharmacological use, absolutely, and we're already doing that. But for this, there are nuances that we've got to be able to incorporate in the machine language to help us. But I think ultimately it will be used.
And I think the variables included when you're asking these questions at all matters, and perhaps why clinical expertise, still can be, a very useful thing to guide.
Yep.
Yeah. Thank you.
Neelam.
So,
she has a list.
No. I had a question for Dr. Ibarra-Jurado. So I think prior treatment with Botox and inconclusive findings on single fiber EMG is something we all struggle with. In your practice, do you have an absolute time where if patients have had Botox, you recommend waiting 6 months or 9 months before? And if you do see something abnormal and the clinical story really doesn't fit with autoimmune MG, do you recommend repeating it?
My friend helped me to translate.
Okay, so he says that the protocol must be different for each patient, because in the experience that they had a patient where the single fiber EMG was abnormal, and 12 months later it was normal. It was abnormal, and then it was fine. So they're finding out that maybe waiting around a year might be enough to actually conclude that.
Thank you.
Thank you.
So in our experience, we have patients looking at perifacial muscles, abnormalities following Botox injection in excess of 10 years. My own personal belief is that if you are looking at periocular, perifacial muscles with jitter, and there's an abnormality in the presence of prior botulinum toxin, you cannot interpret the result of the study. If it is normal, that is excellent to say the patient doesn't have abnormalities there. But if it's abnormal, all bets are off, in my opinion.
I might be misquoting this, Neelam, also, but I think there's a study from quite a long time ago from the Columbia group, including Mitch Brenn and colleagues, showing remote effects of botulism, so EDC abnormalities as well. So it's not like we can just move away from here and go somewhere else.
Yeah, Janice Massey has shown that. We have been injecting 2 units, 3 units into the vocal cords for spasmodic dysphonia, and I can demonstrate jitter in the tibialis anterior 1 week later. So there's huge remote spread.
Dr. Wu?
Hi.
Oh.
Chip, in terms of shared decision-making, do you feel like we have an obligation to include cost in the conversation with the patient at all in terms of cost to society or cost to the individual?
Yes and no. Absolutely, we have to talk about the cost, particularly out-of-pocket cost. And I think it's reasonable to discuss the relevance to society. However, I don't believe we have a good handle on what the cost of treating MG is. And we don't have the health economic data. In Thailand, 58% of the, and if I'm misquoting, Michelle, hit me, but in Thailand, 58% of myasthenics are unemployed. In Japan, it's approaching a third, and there's an additional X percent who have a reduction in income. There's difficulty taking care of their family. In Germany, 45% of people have substantial loss of hours of work. The US, we can't get this number, we're too fractionated. But no one takes into the account, if I can keep you working 40 weeks, what's societal's cost versus if you only work 15 or 20 weeks? And that's never factored in. And so, while yes, it should be, but we have to be careful because the use of these new targeted compounds, while expensive on a per pill basis, one, it's minuscule to what we cost, Zantac to treat GERD, for instance, and we don't take into account these other things. What's the long-term cost of treating diabetes if you're on steroids, or you fracture your spine and now are in chronic pain and having to deal with that? None of this gets factored in by any of the organizations, ICER and everybody else. So yes, I agree, but it's got to be qualified. Juan.
Yeah, so I have a question for Dr. Suehiro. So how repeatable are your results, and to the point where can you do that serially and track? And secondly, have you tried to correlate with FVC, forced vital capacity?
I'm sorry, I beg your pardon.
So when you do your diaphragmatic stimulation, how often is there a significant test-to-test variation? And wouldn't that interfere with tracking and following your results over time to see effective treatment or progression of disease?
Pre-treatment to post-treatment.
Okay, so when we do nerve conduction, your result going to vary each time you do it. It depends on location, stimulus, and so on. Do you see that variation when you do phrenic nerve stimulation?
Electronode is placed 5 centimeter above the xiphoid process, and the reference node is 16 centimeter away, anterior costal margin. And stimulation sternocleidomastoid muscle behind the sternocleidomastoid muscle.
Have you tried to correlate it with forced vital capacity, the results? Breathing, the breathing test, have you tried to correlate with that? To see if there's can you track the difference? That's fine. That's good. Thank you.
I'm sorry.
Yeah, that's fine. Thank you.
All right, thank you. All right, thank you for our speakers. It's my pleasure to conclude our excellent MGFA scientific session. Many thanks to our speakers, our wonderful keynote, and our steering committee, as well as our sponsors. The posters are in Plaza Room A and B and until 3:30. Please enjoy the rest of the meeting.